Hello, good morning. I'm Ashok Rokade, consultant rhinologist and anterior skull base surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior Skull Base Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, the LIONESS, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull base surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilko Grolman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
So without further ado, we start our first session. Can I invite Zara to moderate this session with Puya? With COVID, there are some stars that have come on the horizon of otolaryngology, and that's Puya here, so our COVID expert. So welcome, Puya, and looking forward to your talk.
So good morning, Ashok. Thank you for your invitation, and thanks everyone for joining today. And thank you, Zara Patel, for having me here, and it's always a pleasure. Thank you, Ashok, for your brilliant presentation for this 2 amazing day for comprehensive analysis of data and updates in regards not only to COVID-19, which is the task of mine today, but also for skull base surgery, sinus surgery, and many, many more. So I would suggest everyone to join this and look at this, register, and check it out. So my task today, as said is COVID-19 and rhinology, basically. So may I ask you for the sharing screen possibility? Because I'm not be able, I think that I should be a co-host to do it. Thank you. So my task today is to talk a bit about what is the impact of COVID-19 in rhinology and what changed our specialty. So in regards to that, I would like to, first of all, announce no conflict of interest, announce our ethical committee members from the association. I'm very delighted to have also Zara Patel in this, brilliant one. She gave an enormous, tremendous impact in this during these unprecedented times. So let's go back from 11 March when the declaration of the WHO came with the pandemic. As you see here, we in Italy were the second global nation worldwide with 10,000 cases in the 11 March. The day today, 11 December, sorry for this was 10 December, so 9 months passed. Actually, we still at the 6th place, Italian, and not only for cases, but also for death. That means a lot. Someone will have to talk about this in the future because a small place, a small nation like this, still having these numbers is not good. But whatever it is, let's go back to the fact of 11-12 March when I was declaring my situation with my colleagues in regards to my problem, in regards to my rhinologic problem. I was announcing my colleagues around the world in regards to my situation for anosmia. I was a little bit scared at that time. If you remember, we don't had that information, just few spots around the world, and that affected me. It was 11-12 of March, and that in fact lead me to have, unfortunately, one paper in the Lancet. However, I was positive at that time, and the majority of the journal and in scientific communities were not be able to accept this situation, just some anecdotal evidences, which were also mine. 12 March was this. I will go back to this screenshot because there's something interesting in this screenshot. If you were looking at the 11 March and 12 March, you will see some differences, and we will go through that and we will see what's going on. 15th of April, this paper came out. However, this announcement were already being replied to me when I was sending the message to my colleagues in regards to my anosmia, and this was Zara Patel. Zara Patel was actually taking some precaution for endoscopic transnasal skull base surgery, announcing also all this here. All of our colleagues around the world that were actually saying from China, from Iran, from myself, that, well, look, there's some problem in here. We have some problem. We should announce the people around the world to make some task on this. We should take precaution. We should take precaution not only on the surgery field, but also in office. So we should take precaution. And this lead also not only to the publishing of some anecdotal, but also some evidences that were actually after that being proved around the world from the British National Otolaryngology and Rhinology Society, from the Italian Skull Base Society, and they came after a while. But before that, the 30th March, the first consensus statement came out from ARIA in regards to intranasal corticosteroid. That's very fascinating for me, because if you're looking back to the data, the first statement that came out directly as a position paper were from the IACI, in which they were actually saying what to do and not to do in regards to steroids for those patients, and they were actually saying, look, we don't advise the people to stop intranasal corticosteroid, even if they don't have that information. At least I think that they did something in regard to their position and to their task by taking position and say, look, we will provide information in the future, but by now, keep doing what you're doing. Even if everyone knows that viruses and steroids are not working together. So after that, the 1st April, our European Rhinologic Society came out with some information in regards to this, pretty similar to what Zara were saying in regards to our Chinese colleagues, from Iranian colleagues. Well, I'm Iranian Persian by myself. Also, I was born in Italy, but um, and also by me. And I will always be thankful to these scientific communities that recognize the works of our colleagues and from us, and putting ourselves to tell the people, look, we do have evidences. We have people, we have colleagues in trouble. Be careful. And after that, I'm sorry. I'm sorry. And after that, actually, the situation got a little bit crazy, because after this, I had an enormous problem with myself, and I was able to have a nasopharyngeal swab at that time only because of my blood examination. I was not able to have a nasopharyngeal swab, and my eosinophilic count was the only chance to have that, because it was a huge differences in my eosinophilic count and my D dimer. I remember also 1st of April putting out some information for my colleagues in regard to some specimen and some autopsies carried from my colleagues in Northern Italy, which were saying the thrombophilic vasculitis going on. And this was also recognized in the future from one brilliant colleague, Claire Shoblin. So let's go back in 11 of April. The first impact of some data around the world, from also from Google Trends, to investigate one important topic, which was at that time very, very important for us, was the loss of smell related research during that COVID-19 outbreak. That was very early, published 11 of April. As you can see here, the tremendous increase of search for that. So after our not only mine, but also our around the world announcement, that the people were scared, even if the WHO was not interested in that, but the people were. So we do have credibility, yes. And that's in fact the impact of us made the change. After that, 15th of April, at the same time where we were putting out the information in regard to smell and taste disorders and the impact on people in the surgical field for skull-based surgery, at that time, we already were looking at the future. So what do we have to do to carry on our in-office and our office-based procedures, or in-office patients? So we were making some information in regards to telemedicine. What should we do? We have to look at the future, because we will not be able otherwise to work. In fact, nasal endoscopy was completely shut down after that. And in fact, that came out 3rd of July. So, but we do know that there's some times between, producing a manuscript and being accepted because of the peer review system. Even if early that time, the peer review system was a little bit complicated, as some anecdotal evidences were put it out before. I mean, that was even happened before. It was just the first time ever where anecdotal evidences were accepted as a publication. And in this paper, nasal endoscopy during COVID-19, our colleagues were saying unnecessarily avoiding nasal endoscopy will likely lead to misdiagnosis, delayed diagnosis, and inappropriate delayed treatment. And that's in fact the truth. And we see a lot of patients by now that we are carrying on from that time because of late diagnosis, but we weren't able, because we didn't have enough evidences of what were going on, if we would get exposed or not. And then after that, other consensus treatment were carried on corticosteroid therapy, nasal steroid, or inhalation. And the majority of the people were in fact sure that the oral steroid treatment should be quit, but nasal steroids should be continued. In the patient, however, we should make this clear. They were saying that the patients should carry on their treatment, only those that were with chronic rhinosinusitis that were not appropriately controlled. After this, other paper came out. But I do think that it's a little bit late. If we considering that it's a pandemic and we do need to focus our attention on what to do for visiting, equipment, testing, this time, 4 months, is too much for me. So I think that the majority of the people, not only from our field, but in general, should have considered what to do for the benefits of our patient and for ourselves. So considering PPE internationally recognized. So I think that the organization, a worldwide organization, took too much time to provide some information because this is their task. Other position paper came out from Iyaki and from the ARI group, June 12, in which also they say they were announcing that intranasal corticosteroid remained the standard for the chronic rhinosinusitis in COVID-19 pandemic and also for patients with SARS-CoV-2 infection. I was a little bit scared about this because putting out a reference in this without having data from international society was a little bit too much for me, because putting people in danger is not that great. But they did it. However, they published it the 12th June. It was a consensus, and that should be temporarily discontinued. The patient with biologic treatment that should temporarily discontinued in patient with tested positive. So they took a position for COVID-19 patient by saying intranasal corticosteroids should be continued and temporarily discontinued for biologics. On 18th of June, I like this paper by the American Rhinology Society in which they take position and say, look, we have to see what's going on with research in rhinology. We should see what the pandemic impact had on our people around the world. And they say that our finds indicate that pandemic has negatively impacted a larger number of rhinology research practices. So not only in the fact of the procedure of the patient or the healthcare system, but also in the research. And while we have observed a larger volume of publication related to SARS-CoV-2, the effect on non-medical or surgical practices, we will undoubtedly observe a major negative impact on the research. And this is yes, because the majority of the people were focusing on SARS-CoV-2. Should we blame from this? I don't think so. This is enormous, is a tremendous dramatic situation. Everyone should be focused on something for a short period of time, but at the same time, other people should carry on and do their task. In fact, we do have academics and we do have people that are working in a hospital. Look at the Italian position, for example. I do have to admit, in Italy, we don't do too much for me. The hospital and the university are two separate jurisdiction and two separate things. So one should help each other, but at the same time, they have to do their own. Over here, 24th July. So I'm doing a calendar, day by day to let you know what was going on. We had this review. I was part of it. I was still thanking young IFOS group for having me in this. We were also putting out some information as a systematic review for sinus and anterior skull base surgery. We have put some recommendation in this by summarizing some recommendation for the OR, for considering trainees of fellow, protective measure, for technical specificity for sinus and procedures that should be carried on. After this, I love this one. I'm very glad once again to Zara Patel and Lake Soberby to putting out this together, because this was not only affecting, it was a representative of what were going on, and at that time, how many colleagues we do have lost in this battle, how many people and how many colleagues were actually suffering from this disease, and how many worldwide tried to figure it out what was going on. And a total of 361 otolaryngologists were identified, and data from 325 surgeons was available for analysis with a range of years, and there were 24 deaths. We should, in the future, I really hope that we will take a task and try to remember those colleagues, because 24 at that time, I don't want to even imagine how many other colleagues that because of this. I'm very passionate with this, because it's when it's affecting you by yourself, then you got really mad for this. We should think about these colleagues in the future. I really hope that we will. Other 31 of July, our colleagues, one of my best friend and mentor, Hesham Saleh, and their colleagues put out this Rhinology COVID-19 paper for their experience as a tertiary referral hospital. We do have to remember that this hospital is one of the biggest in the London area. We're putting out some recommendation also for the patient schedules and what should be done in the case of epistaxis for complication, normal complication. Actually, the periorbital cellulitis was one of the first time that I was looking at patients and recommendation for this, and I really love that. But then also we do have to remember that facial plastics is a collaboration of our field, and also this paper came out for Karajan, brilliant. She did a lot. I do have to admit there are some colleagues that really did a lot during this time. Very, very tough. So Zara Patel is one of them, and I do have to admit Claire Hopkins, other colleagues from the Young IFOS group, they did a lot. I tried to do my best too, but some of them were very, very active too. So this review came out August 19 in the middle of the summer, and they also put in some recommendation as based on the literature reviews, and they were actually keep saying, look, we do have to test people before putting them in the surgery in the OR. So that I think that will help a lot if everyone do this. Other people from safe practice guidance from our Egyptian community, friends and colleagues, 6 September, it was a review, and they put an algorithm and a pyramidal axis for elective, expedited, urgent, and immediate. We still having this problem of decisional making for the OR, but I think that this will figure it out very, very soon, also because of the vaccines. 5th of October, and this came out also with the impact of COVID-19 on the ambulatory and operating room. If you look at this, I really like this paper. They are putting out differences between before and during the COVID-19 era. As you can clearly see in here, we do have a tremendous patients not coming at visit in here. But they also analyzing the difference between academic and private activity and their task, but they were actually seeing and looking at while a private practice setting is associated with a greater likelihood of managing epistaxis during the COVID era when compared to academic setting is associated with a great likelihood of performing critical skull base surgery. And I think this is their task. This is nothing new for me. It's completely normal for me in Italy, but the American rhinology, in the US and in places where private practice is one of the most important fact of incoming, we do have to remember that places are different. Our Italian community is based on a national incoming, so it's a little bit different. Same, 19th of October, once again, the Yaki position paper in this. I really think that the Yaki did a lot. They put position paper. They say we do have to do something like this, and I really do believe that other societies should do this. Keep in mind that early 2020, the APOS guidelines came out, so we were actually in trouble with that. And they were actually saying the management of patients with chronic rhinosinusitis during the COVID-19, and they are still saying in regards to surgical treatments, treatment with biologics, and also in regards to intranasal corticosteroid that remain the treatment for chronic rhinosinusitis in patients with SARS-CoV-2. The reason for that, it was because of the possibility of allergic patient for coughing and spreading around. That's because of that. I'm about to end up my presentation. I would like to stress out on this in regards to the editorial from Claire Hopkins, and she were actually putting out some evidences in expediting access or compromising quality by saying, look, we do have to think about what we're doing, and that we must defeat the rigors of high quality peer review and discourage attempts to establish preprint as an accepted form of publishing in the same way that the journal have united against predatory publishers. I do have to admit that this is correct, And what she's saying is actually that we should not take preferred way to publish. We use that, we will use in the future, but we do have to put some limits in this. And I do trust this in regards to the 6 months of maximum 6 months after the acceptance, before the acceptance of the paper, otherwise would leave. Keep in mind, this is my thought that because of preprints, a lot of information came out. Otherwise, would not be possible for that. And this is because of the poverty of the people that were involved for peer review that came out, for example, for our paper for face masks that we submitted before June 1st and after being accepted as a call to action. I really, it took a while to get this accepted because we're a lot of masks for face mask. A lot of organizations will not be able to look at this and accepted face mask. But I'm very happy because we submitted this. The letter to the editor were actually sent to the CDC, and I'm very glad to say that CDC finally also accepted us, and they keep incorporating our call to action in their armamentarium. You can see our face mask paper also in the CDC. Also, we are actually to close 28th of October, telemedicine. They were saying the importance of telemedicine for continue follow up for our patients. We should take out everything and use internet and the telemedicine as a follow-up visit. That's important. And this study found no statistical significant differences in patient satisfaction between video visit and clinical visit. Does satisfaction means proper treatment? Of course not. But we do have to keep in mind that satisfaction for a patient now is to, visiting someone and talk to someone that were not possible before because of, restrictions. So we do have to take some advantage of telemedicine for this. And also there's also very recently, 30 November, for the nasal preparation with local anesthetic should be considered an aerosol generating procedures. I would like to say, do we really, I'm on time or should I quit? Zara?
So I think that that this has been an amazing review of everything that's gone on. Ashok just wanted us to maybe wrap up a little bit. He's going to run a poll in a moment.
I will
your
close.
last two slides. are great to sort of talk about, you know, what you've actually been doing recently in your own clinics, and we can talk about how things might be different between countries across the world.
All right. So the impact of COVID on rhinology. Not at all.
So to everyone that's online, Dr. Rokade has put up a poll so everyone can participate, and it looks like they're looking at, you know, what the current status is. Puya, what is the current status with you right now in Italy?
Counting, we basically doing this in this manner. 3 days before scheduled surgery, even elective surgery, not by now. The problem with us is that we keep going with waves, restrictions. You know, our political and our organization is a little bit quite strange, and it's based on regions which are, you know, density of population is different. So we do have places where we have millions of people and other thousands of people. But generally, what we do is 3 days before surgery, we take nasopharyngeal swab, then we assess this, then we talk to the patient and say, you have to stay in quarantine, that the day of surgery, we do a rapid antigenic test, and then if the patient is negative, we will perform surgery. But unfortunately, parents are not allowed to come and visit the patient, and the patient should stay at a maximum of 3 days inside of the hospital. Then it's discharged. The problem is that critical skull base surgery need follow-up visit, and we should take really in consideration what to do, and that's because of decisional making that will lead to decision based on criticism of the patient. This is true, this is good or not, this is not my task. It's sad. It's just
and
sad.
It actually looks like the results of the poll that were just taken, it sounds like it's kind of along the same way that elective work in a lot of people's practices has been lessened, emergency work maintained. I would say here it's right now, up to now, we've been just doing our normal amount of caseload ever since we completely shut down back in March, figured out the protocol very similar to what you just described, with a pre-surgical type of test, and then taking the patient to the OR safely. We should talk also about the type of PPE that you're using inside, but we're using, N95s and face shields and otherwise masks and gloves. So it sounds like, soon, because of the new surge that's happening in the US, we may have to pull back again on elective cases, but we have not yet, at least here at Stanford. So I think we have maybe just a minute, but what is the current PPE that you're using right now, Puya?
Yeah, the same, practically the same. And during in office, for the patients incoming, just for visiting, we are using surgical mask and N95 upon that. What about me? I'm using surgical mask alone because I still think that, just by saying this, we currently submitted our research for antibody persistency at 8 months. I had my blood test 2 days ago, and my antibody is still present. It's very fascinating how to say. What we analyzed was basically that patients were that still having antibodies are those ones that are moderately severe patients, and that the fact that the antibodies persistency still after 8 months, it doesn't mean that you don't have to wear PPE. We are carrier. We should be careful. We should think about the viral load and inoculum size, and the prevention of that is made by face mask. And I think that majority of the people still recognize the importance of this. I really do hope that we will figure it out and leave those face masks as soon as possible. I will pray for that, to see everyone again in a, not only in
I do too. I hate it. So on that note, thank you so much for such a great talk. I'm going to throw it back to Ashok, and I think we have to continue with the program.
Okay, thanks, Zara. Thanks, Pierre. That was a really informative, wonderful talk.